We know in United States, the incidence of IgA nephropathy is roughly around 10 to 20%. When we move on to Europe, it comes around 20 to 30%. And if it still comes to Asia, it will come around 30 to 40% or even 50%. Surprisingly, in South Africa, it is very less, somewhere around 5%. Why? We know in United States, the incidence of IgA nephropathy is roughly around 10 to 20%. When we move on to Europe, it comes around 20 to 30%. And if it still comes to Asia, it will come around 30 to 40% or even 50%. Surprisingly, in South Africa, it is very less, somewhere around 5%. Why? We know in United States, the incidence of IgA nephropathy is roughly around 10 to 20%. When we move on to Europe, it comes around 20 to 30%. Okay. Anyway, so IgA nephropathy, as a nephrologist, we know that IgA is deposited in the glomeruli. What IgA? It is a polymeric IgA. So where does this polymeric IgA come? It should come from the mucosa. So we'll move on to the mucosa. What is happening? So mucosa is a wonderful organ. Its surface area is around 350, 360 square meter. It is bombarded with more than 50% of lymphocytes. That shows the importance of this defense mechanism. As we know, 95% of our infections is through this mucous membrane. So there should be a appropriate pakka defense mechanisms to cope up with this organism. So naturally, we have got gut-associated lymphoid tissue. It may include Walde's rings to Payet's patches in the ileum. So there is an epithelial cell, submucosa full of this lymphoid tissue. Whenever there is a microbe or some form of problem occurs to this mucosa, it will sense this as damaged associated protein or pathogen-associated things, or even the microorganism. This signal will be given to the B lymphocytes. How? There are two mechanisms. One is T-dependent mechanism is there, T-independent mechanism is there. Why I'm stressing is there, we are focusing on the treatment strategies of the IgA nephropathy depending upon the mechanism. This T-cell independent mechanism, as you all know, there are some B-cell stimulating factors like APRIL and BAFF. APRIL is a proliferative ligand, so also BAFF is a stimulating factor. These two factors are coming in the T-cell independent pathway, probably due to the dendritic cells sense these signals, and then through the T-toll-like receptors, it may give you signals to B cells. Anyway, there is another pathway, T-cell dependent pathway is there. Lot of TH1, TH2, we all are familiar in the transplantation, TH1, TH2. In IgA nephropathy, there is a disparity between TH1 and TH2. There will be a dominance of TH2 and the sequelae. So naturally, interleukins are coming. This will also prime the B cells in the mucosa or submucosas to produce antibodies. So naturally, we expect in a case of mucosa infection, natural IgA antibodies. But in case of IgA nephropathy, it is an abnormal IgA. Why? Again, it may be explained with genetic or ethnic background. So anyway, some abnormal IgA is formed in this particular IgA nephropathy situation. What is this abnormal IgA? You know that IgA having two heavy chain and two light chain. And this heavy chain is connected with disulfide bonds. But peculiarity of IgA1 polymer is that we have got IgA1 and IgA2. IgA1 has got a hinge region, just like our protein. It is a flexible area. It consists of 17 amino acids. Out of the 17 amino acids, 9 amino acids are threonine or serine. As you know, serine and threonine are hydroxylate OH bonded amino acids. So naturally in IgA formation, natural formation, this particular amino acid has to be galactosylated. That is, a galactose moiety should attach to this particular IgA. That is normally happening. Before that, first step is N-acetyl galactosamine is attached to a hydroxyl group of these 7 or 9 amino acids. That is a normal process. Second step is, after this N-acetyl galactosamine attachment, another galactose molecule is attached to this moiety. This is the very important step. But in IgA nephropathy, IgA1 is abnormal. In what way is abnormal mean? There is no galactosylation takes place. Why there is no galactosylation takes place? As we all know, this galactosylation is depending upon one particular enzyme, galactosyl transferase. Is it abnormality or is it driven for the genetic? As far as we know, the current concept is there is a genetics. There is a single polymorphism in the gene that concerns the production of this galactosyl transferase. But it is not the abnormality that causes a galactosylation abnormality in IgA. Why? In IgD, we know that well-known galactosylated moiety, nicely galactosylation takes place in IgD. So it is not the galactosylation problem, it is not the genetically driven abnormality. So what is the problem? Genetically driven abnormality patients has got another aspect. We are all familiar with microRNAs. By 2020, this microRNA has got very good biomarker, therapeutic target, lot of things will be there. In IgA nephropathy, our interest is there are two microRNAs. One microRNA is this 148B. This will come to attach to the messenger RNA of this transferase enzyme. But in all the cases, it will not get attached. Whenever there is a single polymorphism in the gene, there is an abnormality to which this microRNA. So that is why there is a lot of heterogeneous population, heterogeneous varieties in IgA nephropathy. This particular microRNA will cause abnormality of the galactosylation. Another important factor or player in this regard is chaperone. Chaperone, you know, this chaperone moiety will finally convert the molecules into folder or unfolded state. Once there is IgA molecule is formed, this chaperone will get proper folding. But in case of IgA nephropathy, chaperone has got another problem. Chaperone is not normal. So this normal IgA cannot fold properly. So these are the two abnormalities with which there is defective galactosylation takes place. If you go back to the original IgA molecular structure, we can see that these are the steps. This is N-acetyl galactose is attached, and there is a galactose moiety is attached. But in case of IgA nephropathy, there is no galactose attachment. And funny thing is that there is another molecule looking on this IgA molecule, that is sialic acid or polynoramic acid. If there is no galactose, it will attach to that place. Even if there is an attachment of sialic acid to this IgA molecule, galactose cannot enter into this molecule. That is another problem. So there are three problems, either due to microRNA, or either due to chaperone, or either due to sialic acid acylation. So anyway, we have got an abnormal IgA in case of this. And what is happening? If you trace the IgA producing cells in the submucosa, the number is not high. From where this IgA is coming enormously? So we should find out another reason. So explanation is that this primed B cells or the plasmablasts will go back to spleen or bone marrow. That is called mistrafficking. So we can easily say that homing factors are not there or anti-homing factors are there. That is why these plasmablasts are going to the bone marrow or spleen. There they get accumulated and in due course produce lot of abnormal IgA molecule. Now we know that there is an abnormal IgA molecule coming into the circulation. What is the abnormality? We know the hinge region is abnormality. What is the significance? It is reported that the level of this abnormal IgA to C3 level will denote the progression of chronic kidney disease. So if you are able to identify this particular factor, you can pinpoint the progression of kidney disease. Then naturally, whenever there is a neo-epitope or abnormal epitope coming into our system, there will be naturally an antibody formation. So this hinge region, poorly galactosylation moiety is a new antigen against which an antibody will form. That is the antibody against defective galactosylated IgA1. This antibody may be IgM, IgG, IgA, like that. But very often it should be IgA and it should be IgG. So what is the importance of this antibody? Another importance is that in this particular antibody, let it be IgG or IgA, there is a position in the S segment of the variable region of the molecule, which will attract abnormal IgA1. So there is facilitating the combination of this abnormal antigen and antibody, but it is also not genetically driven. It is a somatic mutation. So anyway, we have got aberrantly glycosylated IgA1. We have got an antibody. This antibody and antigen complex will get circulated in the system. Finally, it will get trapped in the kidney. As usual, in any case of immune complex disease. Why? Probably because of defective clearance. Before that, when you take the immune deposits in IgA, we can have IgM, IgA, and IgG. Very often, in majority of our studies, we know that there are no IgG deposit in all 100% of cases. The studies are reported that they have eluted IgG from the specimen and find out that even if there is immunofluorescence 0 for IgG, in all cases, slight amount of IgG is there. That shows an importance of the progression of kidney disease. So with the special technique, even we can look for this IgG. So once there is antigen and antibody complex is formed in the circulation, defective clearance is there. Why it is defectively cleared? Usually it is the liver that clear all these organisms, all these molecules. But in case of abnormal or IgA nephropathy, there is increased sialation, that is polyneuramic acid is more. Thereby, the liver cannot take up this particular molecule. And again, there is decreased galactose. The Kupffer cells of the liver cannot take up this molecule. So the proper degradation of this immune complex is not taking place. Thereby, there is increased chance of deposition in the kidney. What is happening in the kidney? In the mesangial cell, it is looking for these immune complexes. Why? Receptors are more. Overexpression of this defective galactose immune complex absorption is more in case of mesangial cells. More trapping will be there, and mesangial clearance is also decreased in IgA. So even though we say that there is a multi-hit theory or a poly-hit theory or hit-for theory, lot of polymorphisms in the pathogenesis of IgA occur. Once there is immune complex, that is antigen antibody occurs in the kidney, what happens naturally in all other cases of glomerular disease, there could be an activation of complement. We know that there is a classical pathway, lectin pathway, alternate pathway. We all know that the alternate pathway is the usual pathway taking place in IgA nephropathy. But surprisingly, for the last 10 or 8 years back, we came to know that there is another pathway called a lectin pathway, because this IgA containing mannose, this mannan can be detected by our lectin. So this detection of this mannose by the lectin pathway will go on to stimulate the subsequent enzymes like mannose binding lectin, serine protein. Again, there is a serine proteins. There are 3 proteins are there. 2 is the most important. And once you stimulate the serine protease 2, it will go on to produce subsequent steps so as to produce C3 activation. So in IgA nephropathy, we know that there are two lines of activation of C3. One is the classical alternate pathway, and another is the lectin pathway. So finally, it will go on to C5 and terminal complex. So otherwise, IgA nephropathy starting the journey from the mucosa, ending in the glomerular disease with the different aspects of polymorphism. We cannot say it is only a 4-hit theory, multiple theories are there. Even galactosyl transferase are 20 in number in the body. So a lot of changes can occur. So we cannot pinpoint one single entity as the cause of pathogenesis of IgA nephropathy. Anyway, this immunocomplement is activated. If you happen to see the biopsy, you can identify C3. In 90%, more than 90% of cases, there will be C3 will be there. So naturally, C4D is there. C3 and C5 proper in factor H. And important thing is complement factor H. In Africa, why there is decreased IgA, it is found that there is a deletion of complement factor H. Protein R1, R3, R5 are deleted. That is why they are not getting this sort of IgA nephropathy. That may be the explanation. So in a nutshell, you can see all this sort of immunofluorescence pattern in IgA nephropathy. So in nutshell, we will start from the history lumen. Lot of bacteria or antigens are coming. B cell priming are there. Abnormal IgA are formed. Abnormal IgA producing abnormal antibodies are there. May be decided by the genetic background. And these complexes will get trapped in the kidney, in the mesangium, mesangial cells proliferation, mesangial matrix cells increase, subsequent oxidative inflammatory changes so as to produce fibrous, a scarred kidney in the later phase of the disease. So that is the pathogenesis. We are all familiar with the MEST score. It is very important to predict the outcome of the diseases. And this is a short study from our center, Kottayam. 10 years back, we have studied C4D in IgA nephropathy. And it was found that total there was about 247 patients. Out of 124 patients were having C4D. What is the peculiarity of C4D minus or C4D plus? C4D positive patients had greater complications like nephrotic range, proteinuria, more hypertension, more renal failure. And in the pathology, we have seen that lot of chronic changes occur, sclerotic changes, interstitial fibrosis, tubular, lot of chronic changes are more in favor of C4D changes. And we had such those 147 patients follow up, and we had a 12 transplantation for C4D group. Fortunately, after so far 10 or 12 years, so far we didn't have any recurrence of IgA nephropathy in this group. Anyway, this is the pathogenesis. As we all know, the current concept of pathogenesis. Why we are interested is we can attack each step in the pathogenesis so as to alleviate the symptoms. So the therapy means specific therapy should be there. It may be due to at the mucosa level. It may be due to at the antigen level, maybe at the immune complex level, maybe at the level of the trapping of the kidney, and subsequent steps are there. And any glomerular disease, you can have a generic therapy. To prevent scarring, you can have a lot of measures are there. Then the current concept, depending upon the proteinuria and depending upon the GFR, you assess the risk stratification in IgA nephropathy. If there is less than 1 gram proteinuria and the GFR is more than 50, you can have optimized control. That is adequate blood pressure control with the tolerant ARB or ACP, not with both, and control of the other cardiovascular problem like dyslipidemia, smoking, weight reduction, exercise like that. So we can follow, but still we are not in a happy mood because we are not in a position to arrest the progression of majority of IgA nephropathy. Roughly 40 to 50 patients land up in ESRD. So if you go back to the landmark trials in IgA nephropathy, POSI and all started the steroid therapy long way back. That is before the ACE ARB introduction. So we know that POSI introduced a steroid for a good thing for IgA nephropathy. Naturally, we came back to stop IgA and testing trial with the high dose steroid. Still, we are not happy. We are experiencing a lot of steroid side effects. We are not happy with the progression of kidney disease. Even with the steroids, even with the cyclophosphamide, even with azathioprine, even with the methylprednisolone in testing cell, we are not able to arrest the progression. We are not able to preserve the GFR. So we are in a difficult situation. So what else we have to do? So depending on pathogenesis, this is the stop IgA therapy. We have concluded that thing. Stop IgA and testing, we are not happy. And now we have to identify the risk factor for chronic IgA nephropathy. There is a various protocols and there is a prediction tool depending upon the age, ethnicity, blood pressure, serum creatinine, and MEST score. And that ethnicity is the most important thing with which you can stratify the risk of an IgA patient and to say that what is the nature of the progression of kidney disease, the 5 years or 10 years. Anyway. This is the background. How you can treat IgA nephropathy with the specific therapies. So this we will go on to where all you can attack. You have got intestinal lumen, environmental dietary antigen. You take off all this dietary and environmental antigen. It was found that in experimental mouse model, even if there is a BAF and T regulator cell reduction, increased BAF and T regulator cell reduction, which is a prerequisite for IgA nephropathy. And if you are not giving any bacteria into the tube lumen, IgA nephropathy will not occur even with a predisposed individual. So it is not possible. So then mucosal infection you can treat with antibiotics or some other things, but it is very difficult to treat all the bacteria. You know, trillions of bacteria staying in the gut. So it is not difficult. Even if you eradicate all the mucosa, super infection may control. So our task is to give something that you can manipulate the response from the B cells. How can you do? It is well known that in inflammatory bowel disease, the gastroenterologists are using budesonide in this way or that way. So why can't you use budesonide acting as a local anti-inflammatory agent in the ileum? So budesonide trials are there. Then we have got B cells are there. APRIL and BAF is there. You give anti-APRIL, anti-BAF therapy will be there. So they have got the IgA antibody complex is there. You take off all these IgA. We are all familiar with antibody-mediated rejection. There is a protease enzyme that will degenerate or remove the IgG molecule. Like that, you can use IgA protease. Then coming back to our kidney, you can inhibit the mesangial proliferation with the various steps, and you can attack complement system also. So this is the nutshell of the specific therapies. So this is the initial observation of budesonide in 16 patients of IgA nephropathy. They have treated with 8 milligram of budesonide. Surprisingly, they have found 21% reduction in proteinuria and 7% increase in GFR. That was the first surprising study with the Neficon. Then they move on to Nefigan study. Nefigan study, they have used 2 different strengths of budesonide, 16 milligram and 8 milligram with the placebo, and it was good. It was found that lot of improvement in the proteinuria, and there is definitely a preservation of GFR. That is Nefigan study, but there are a lot of side effects because they have gone 16 milligram and 8 milligram. Notice a lot of steroid side effects. Though we know that budesonide is a first pass metabolism drug, it will not have anything in the systemic circulation. But in this study, about 25 patients out of 100 went out from the study because of the side effects, mainly because of Cushinod features and all this. So that is a limitation for the Nefigan study. Now they are moving to Nefigat study with a newer protocol with the 16 milligram of the result has not come, but the initial report saying that 1 year after this study, proteinuria has definitely come down by 27%. And the GFR is preserved in roughly around 8%. So probably in the future, by next year or so, we may get the good results of this Nefigat study. So these are the studies with budesonide. That is silencing the B cells in the PX patches. Then what else we can do? This we know toll-like receptors are going signals to APRIL and BAF. Why can't you attack APRIL? anti-APRIL you give, anti-BAF you give, see the response. So there is a study with anti-APRIL. This initially they studied in the healthy human volunteers. How far it will act? They did with the different doses, 0.5, 2, 6, and 12 milligram per kilogram body weight of anti-APRIL. And it was found that surprisingly, IgA, that is defective IgA was decreased, immune complex has decreased, IgM, IgA, and IgA antibodies. So probably this will be useful for our studies in an IgA nephropathy patients. So there are two studies. The molecule they have not identified. It is written as WIS649. It was good. There is increased GFR and reduced protein. That is trial is coming up. And the next one is another trial with Bion 130. The molecule has not name. And again, surprisingly, very good result. Almost all these studies showing 20 to 25 reduction in proteinuria and preservation of 5 to 8% of GFR. You know, I am going to show only the positive studies. So this is a second April study. Then why can't you go to BAF? BAF, that is B cell stimulator. That we know that there is a molecule called bisblimod. It 100 milligram, 200 milligram dose. They are trying with the dosage. And it was also surprisingly very good. Decreased proteinuria and decreased GFR. So this is the patent they have announced with the proteinuria and creatinine. Proteinuria definitely came down 2.0 to 1.18 in this drug group. And GFR is well preserved. Probably in the future, that may be good. There is another molecule called atacicept. It will block, it is a fusion protein. It will attack APRIL and BAF. May be useful in case of IgA nephropathy. They have identified only the proteinuria, not the GFR. They have identified reduction in proteinuria after 16 or 24 weeks. So again, that molecule may be good in IgA nephropathy. Now comes the complement. We know that complement is activated in two pathways, lectin pathways and alternate pathway. So why can't you block this particular enzyme? That is mannose lectin binding associate serine protease. So serine protease may be inhibited by a molecule called narsoplimab. And it is very good. Surprisingly, the important thing is that even with advanced renal failure of IgA nephropathy, this particular molecule may be used. So there is reduction of 61% of proteinuria. And surprisingly, the GFR with the even GFR less than 35 ml, they have selected patients and found to be useful. Why? It is not because of the glomerular disease. This particular molecule will attack on the complement system in the glomerular level, and it will attack on the tubulointerstitial level, further progression of fibrosis cystectomy. So in that way, it's going to be a very big molecule. In the proper author, that is John and Barrett, has personally announced that this is going to be a very good molecule in the armamentarium of IgA. As you know, in corona also you can use the same molecule because corona is also attacking the mannose lectin pathway. So there is a lot of possibilities for this particular molecule will be there. Then actually we have got other molecules like iptacopan, that is anti-B factor. You have in alternate pathway, you have got B factor. B factor is converted into C3b and BB. So you have got H factor, I factor, so many factors. So against anti-B, they are giving a trial. And again showing there is 23% reduction in proteinuria. Probably in the future it may be good. And that is called iptacopan. It is reducing definitely the proteinuria in the experimental group. And actually we have got C3, then we have got C5, C5A and C5A receptor is there. Attacking C5 in the liver, there is a molecule under trial. And anti-C5 eculizumab is also under trial. Not yet announced the further result. You have got C5A receptor. And receptor will be blocked with the avacopan. It may be useful in IgA nephropathy. And in a small group of patients, it was noticed that IgA nephropathy patients having decreased proteinuria and preservation of GFR. So a lot of good things are coming from the complement system inhibition and the pathogenetic pathway. Probably in the future, it may be useful. And any other glomerular disease, we have got endothelin, we have announced in the previous talk, endothelin angiotensin II receptor blocker is there. So it's a PROTECT study. This is also ongoing study. And actually, any study, we are expecting reduction in proteinuria and sparsentan and the atrasentan is also coming as an aligned study. These studies are going on. We may get the results only after 1 or 2 years. And generally, our dapagliflozin, everywhere we are using dapagliflozin for the cardiac, renal, and everywhere. We know that there is anti-proteinuric effect because of the tubuloglomerular feedback mechanism. So it is very good in IgA nephropathy, it was found. So naturally, dapagliflozin is another option change in proteinuria and change from baseline eGFR is very good, acceptable. Probably in the future, we may get much more results from the dapagliflozin. In a nutshell, we have got, you can attack mucosa, you can remove the bacteria, you can give antibiotics, and the present concept is programmed cells are coming in the gut mucosa to alleviate the selective microbiota. So microbiota management is important. As in any other diseases nowadays, we have to, we may be able to control the IgA nephropathy. Then budesonide, we have discussed. TLR inhibitors, we know HCQ, our friend HCQ, we are using everywhere. HCQ may be a possible drug in IgA nephropathy, probably at the level of toll-like receptor acetyl-like, probably at the level of the chemokines in the mesangial it may act. So probably this hydroxychloroquine study is ongoing. Around 200 patients with 200-400 milligram HCQ is going on. And initial reports saying that 1 year after the enrollment of the patients, there is a reduction of proteinuria about 20% and preservation of GFR. Probably in the future, HCQ may come as a good molecule. And then we have got, we have mentioned about budesonide. All the factors that will alleviate the inflammatory things in the kidney. So there are a lot of inflammasomes, lot of anti-inflammasomes are there. Thereby you can attack nuclear factor Kb, thereby caspase. So a lot of things you can, as in general, they can give. Then you can have removal of IgA from IgA complex. That is, you give protease, which is derived from the Streptococcus pneumoniae or Neisseria gonorrhoeae. These are the bacteria which will give this particular protease. If you give experimentally in experimental mouse model, it was found that even you can remove IgA from the mesenchyme of the mesenchyme of the kidney. So in the future, just like in the case of antibody-mediated rejection, we may be able to give this. Things will be there. Then a lot of other molecules like fosmanogepix, that is tyrosine kinase inhibitor, they have tried, but not much effect. That is proteinuria or GFR, there is not much effect on this. And you are wondering, rituximab or our whatever be the disease, we are all thinking about rituximab. What is the role of rituximab in IgA? No role at all. Why? Absolutely no effect of rituximab in IgA nephropathy. Probably because this particular molecule or rituximab may not attack our plasmablasts. You know that is rituximab is acting on the B cell. And these abnormal plasmablasts are moving to the bone marrow or spleen or residing in the mucus. That might be the result. Still, though, despite the negative results of rituximab, now there is a new recruitments for the trial is going on with the rituximab. Probably we may get a good or bad results. So these are the different drugs that are possible with the management. Then regulation of gut microbiota, I said that is removal of the removal of microorganisms, then programmed cells. Then transplantation, fecal transplantation, another option where thereby you can select some organism, put it into the gut. And in IgA nephropathy, it was found that there are a lot of changes taking place in the microbiota in the gut. There are E. coli is coming and some other grave bacteria is coming, and there is less bacteroids will be fusobacterium. So you can modify this microbiota. Then T cell modulation, I told you that there is a T cell independent pathway. There is a Th1, Th2 imbalance is there, and Th2 is dominating, thereby producing Th17, T5, and T22. All these producing bad molecules for the genesis of pathogenesis. Why can you attack the T cell and modify the pathogenesis? Then cleavage of IgA, already said. Then regulation of inflammasome and all those things. And most important, now fashion is autophagy. That is, upavasam is good for all those things in the medicine. Now you know that whenever you upavasigia, your all bad things will be cleared. You are clearing your fridge, you are clearing your room and all those things in your house. Why can't you remove your bad things from your body by taking upavasa? That is autophagy. So what is autophagy happening in the kidney? In case of IgA nephropathy, there is an mTOR pathway that causes the decreased apoptosis, decreased autophagy taking place in IgA nephropathy. It is because of the mTOR pathway activation. NF-kappa beta then finally comes to mTOR pathway, and mTOR pathway activation produces decreased apoptosis of the podocyte and decreased apoptosis of other cells first to produce bad things in IgA nephropathy. So why can't you give inhibition of mTOR pathway by your rapamycin? We are all familiar. So these are the things that are coming in the future. So many things we have discussed. That everything is in the horizon. Only Nefecon, that is budesonide, is in your hand. FDA approved only one molecule. All other things, the results are we are expecting. Probably we may get. So till now, till then we have to go with your optimized goal-directed therapy. So additional glomerular capillary wall, that SGLT inhibitor may be helpful current concepts. So finally, what testing trial the stop IgA trial, we have to move on to the some other drugs which will not produce side effects like steroids or other drugs. So we have got a lot of studies, phase 2, phase 3 studies are going on. We may get a good results in the future, probably. So in nutshell, this is the way you can manage your IgA nephropathy patient, starting from the mucosa, going to the B cell and T cell, going to the immune complex, then going to the trapping in the kidney. And so this is in nutshell the various pathogenesis-based treatment of IgA nephropathy. Then lastly, this talk, I have to remember my great teacher. My teachers who modified me or molded me as a nephrologist like this, starting from my great teacher, Kashi Vishweshwaran sir, my Vimala madam, and Ramdas Pisharody sir. And Ramdas Pisharody sir was, he was my examiner, he was my teacher. ഞങ്ങൾ ഒരുമിച്ച് കോഴിക്കോട്ട് ഒരു ക്വാർട്ടേഴ്സിൽ സാമ്പാറും പുളിശ്ശേരിയും വെച്ച് ജീവിച്ച കാലങ്ങളുണ്ട്. ഞാൻ സാറിൻ്റെ കൂടെയും കാർഡിയോളജിയിലെ വേണുഗോപാൽ സാറിൻ്റെ ഇതേമാതിരി ടോക്ക് കേൾക്കാൻ പോയ സമയം ഞാൻ അവരുടെ ഡ്രൈവറായി പോയി. ബിക്കോസ് യു നോ ദ റീസൺ. ഒരു നട്ടുപാതിരേക്ക് നല്ല മഴയത്ത് 2 സാറന്മാരും കൂടെ എൻ്റെ വീട്ടിൽ വന്ന് എന്നെ വിളിച്ചു. സോ ലോട്ട് ഓഫ് പ്ലസന്റ് മെമ്മറീസ് ആർ ദർ വിത്ത് രാംദാസ് പിഷാരടി സാർ. ഇവരൊക്കെ കൂടിയാണ് ഞാൻ എന്തെങ്കിലും നെഫ്രോളൈസ് ആയിട്ടുണ്ടെങ്കിൽ ആയിട്ടുള്ളതെന്ന് യാതൊരു സംശയവുമില്ല. ദെൻ നാച്ചുറലി സാറ് മരിക്കുന്നതിന് മുമ്പ് ഒരു 3-4 ദിവസം, I don't know why, that another photo he sent to me. He was a nephrologist, you know, he's a brilliant nephrologist teacher and all. But സാറിൻ്റെ ഞാനുമായിട്ടുള്ള ബന്ധം അതിനപ്പുറമായിരുന്നു. സാർ യൂസ് ടു send some other things. This is a photo sent to me few days back. സാർ മരിക്കുന്നതിന് ഒരു 3-4 ദിവസം വായിച്ചാണ്. നിങ്ങൾക്ക് പലർക്കും ഇത് അറിയണ്ടാവില്ല. ഇതൊരു കഥകളി അനശ്വരരായ അതുല്യ പ്രതിഭകളുടെ ഒരു പടമാണ്. ഒരു പക്ഷേ നിങ്ങൾ മലയാളം ഒരു പാട്ട് കേട്ടിട്ടുണ്ടാവും, ഉത്തരാസയമരം കഥകളി കാണുവാൻ ഉത്രാട രാത്രിയിൽ പോയിരുന്നു. അതിലിങ്ങനെ ലൈൻ പാടി വരുമ്പോൾ മാങ്കുളം ബൃഹന്തളയായി ഹരിപ്പാട്ടു രാമകൃഷ്ണൻ വലലനായി, എന്നിട്ട് ഗുരുചങ്ങൾ അവരൊക്കെയാണ് നിൽക്കുന്നത്. അപ്പോൾ സാർ എന്നോട് ചോദിച്ച ചോദ്യമാണ്, ജയകുമാർ ഐഡന്റിഫൈ മാങ്കുളം. വെരി ഡിഫിക്കൽട്ട് ഫോർ മീ. പക്ഷേ എനിക്ക് സാറിന് ഉത്തരം കൊടുക്കാൻ പറ്റിയില്ല. സോ ദാറ്റ് വാസ് ദ ലാസ്റ്റ് കമ്മ്യൂണിക്കേഷൻ വിത്ത് മൈ ടീച്ചർ രാംദാസ് പിഷാരടി സാർ. സാറിൻ്റെ ഓർമ്മകൾ ഇന്നും മനസ്സിൽ നിൽക്കുകയാണ്. ഇറ്റ്സ് എ ഗ്രേറ്റ് ടീച്ചർ, ഗ്രേറ്റ് ഫെലോ ആൻഡ് ഇറ്റ്സ് എൻ എൽഡർ ബ്രദർ ടു മീ. സാറിൻ്റെ ഓർമ്മകൾ ഞങ്ങൾ ഇങ്ങനെ ഒരു CME നടത്തി ചെയ്യുന്നു. സാറിൻ്റെ ആത്മാവ് ഞങ്ങളോട് സ്നേഹിക്കണേ എന്ന് പ്രാർത്ഥിക്കുകയാണ്. സോ ഐ വിൽ സ്റ്റോപ്പ് മൈ ടോക്ക് ഓൺ pathogenesis by IgA nephropathy. This is the thing. New things are coming. Everything is in the horizon. So very easy to present because don't have any dispute and all. Everything is coming in the next year or another 2 years. So in nutshell, I have drawn the picture of how pathogenesis occurs in IgA nephropathy. It is a mucosal disease. Gastroenterologists will say that it is a mucosal disease, is their disease. Starting from the mucosa, abnormal IgA, antibody to this abnormal IgA, immune complexes trapped in the kidney, and basically a fibrous kidney is forming. So we are applying our knowledge at various levels of these steps to inhibit the pathogenesis of IgA nephropathy. Thank you. And thank you, Dr. Sadish and Trivandrum Nephrology for giving me this wonderful thing. I think somebody has said great speakers are coming. I am wondering why they are saying they might not have remembered me. But probably Sadish Palan took this opportunity because I had studied C4D. That is even 10 years back from Kottayam, or thanks to my DM postgraduates and colleagues at Kottayam. We have studied 147 IgA patients divided to C4D and C4D negative, and Dr. Roshan got the Tanger Prize presentation. Kashi sir was one of the judges for that paper. So anyway, so nice. Thank you, Dr. Sadish and Trivandrum Nephrology Club for giving me this wonderful opportunity. Thank you all for your patience.
This is a modern era of precision medicine, and precision medicine, the good example is IgA nephropathy, as you just know. So the pathophysiology is beautifully elucidated, and the different targets for the treatment and where will we be in the next 10 or 15 years is what Dr. Jayakumar did in a beautiful way. Thank you, Dr. Jayakumar, for that excellent talk. Now the topic is open for discussion.
Sir, now that we understand the pathophysiology better, do you still think that there's a role for tonsillectomy?
Yeah, very good question. Because as you know, gut-associated lymphodepletion, tonsil will also come while dressing is there. And tonsillectomy is a controversial issue. KDIGO, as you might have read, KDIGO assisted, it is possible in Japanese people. Why? This tonsillectomy, routinely we know that this tonsil has got crypts, surface area is great, and microorganisms like a Haemophilus influenza and syncytial viruses, some other viruses produce all sorts of things. Naturally, in IgA nephropathy, that will happen. Once you knock off this tonsil, you are not knocking off all other lymphoid tissue. In the industry, a lot of lymphoid tissue. And another thing is that they have done tonsillectomy without any proper scientific division. So immediately they took some IgA nephropathy patients and took tonsillectomy, and they did the study. That was the drawback of that study. And it was noticed that this particular study, tonsillectomy plus pulsed steroid was one group, and another group was the pulsed steroid. So it was the pulsed steroid might be a supportive factor for the good health. So finally, we concluded that in Japanese, this tonsillectomy may be useful. In all other parts, it not at all useful. Okay.
Do you still think that we could have a randomized control trial or some, at least a retrospective trial? With steroid, without steroids?
Definitely, you are correct. We need all such studies. Then only you can engage.
Thank you, sir.
I will repeat. Yes. Is that?
Yeah, budesonide oral.
Budesonide is available or not?
No. Have you got any experience with that?
No.
Use
I have not
IgA.
yet started. No, sir.
Can I just ask one question? Is this, you mentioned that this can be used in different stages at different targets. So is there any study which showing that can be combined?
No such studies are there. No such studies are. Combined IgA nephropathy has come to the market. That is, along with other glomerular disease, you are getting IgA. Not combination of the drugs has come.
So it was excellent
You
presentation.
are anti-April. I know.
Actually, Trivandrum Medical College is encouraged experience in April and BAFund. We did a study on how April levels are influencing the histopathology of IgA nephropathy, but we didn't find any positive correlation apart from only in patient with carcinic IgA, you have high April levels, and even glycosylated IgD-A1, that is also didn't have any correlation with the morphology of IgA nephropathy. And after that, we actually are part of this Envision VI-169 study. Sibeprenlimab is the molecule. Interim analysis yet to come. Probably they are saying that there's a wonderful drug which can change the IgA therapy. And they are planning for an open label extension in another 6 months' time. So I humbly request all NAK members, if you have a patient who you would like to enroll in a Sibeprenlimab study, you can refer to medical college. The entire this genomic study, everything will be done free of cost, and probably it's a randomized. But once it is open label, anyway, patient will get Sibeprenlimab study. Okay, so this is a request for.
Thank you, Dr. Noble. What you said, Noble. What you said. You have done your no. We should know, because these are coming up. There is an April molecule, sir. We are giving anti-April, and you showed that there is no histological
correlation.
That means
no. The problem is, sir, the IgA presentation itself is very pleomorphic. That is, some patient will come with 50% atrophy. Some patient will simple microscopic hematuria. You get only mesangial IgA with mild proliferation. So that is the problem with. That is why when we send this study to most of the international journal, they rejected, because the 30 patients we had all had different morphology of IgA presentation. Even GFR was very different. Somebody will have GFR of 15, somebody will have GFR of 90. So we couldn't say that this is because this. So that is why most of our journals said we can't stratify cases because numbers were less. So probably we need all IgA, we should need if we have a very good number, then probably we'll we can show some results.
Very good. That is in April study, they have quoted is that they have given this particular molecule, then they assessed by, that is IgA, serum IgA abnormal molecule and immune complex. They have not checked this histological pattern. As you said, IgA nephropathy, the peculiarities is heterogeneous. Though we simply said IgA deposition. So different patterns, individual variations are so difficult. Only thing we can stratify. Suppose you are getting histology and retrospective, you see the bodies. Histology wise, you can score MST score, how much it is chronic or fibrous like that, then you can correlate. Otherwise, simply doing April and simply doing histology may not give you the answer.
Yeah, even the April.
But these are highly theoretical. So we may get some knowledge. These are purely theoretical. This BAF and April are doing lot of uncinessalies, as we know. So anyway, it will be a learning process. Good. Thank you.
Two questions are there from the Zoom audience. One was on, was MMF useful in the non-Chinese group?
Yeah, MMF in general not used at all. Then where will you use MMF? Japanese people used to use MMF, but how we Indian people use, if you have difficulty to treat with steroids or the patient is not agreeing with your steroid therapy, option is MMF.
There's one more question on budesonide. Was budesonide used separately or is it along with oral steroids? Now,
No. Our aim is to minimize the steroid side effects. You are giving prednisolone and the child will, as Dr. Singh has said, moon face, everything, short surgery, everything. So avoid all these things. We are going to another molecule, and budesonide is such a molecule. It has got a first pass metabolism that if you take the budesonide, it will go into the liver and completely destroy. Only 10% will be coming. That is a theoretical thing. No more side effects. But practically in the Nefigan study, 25 patients out of 100 went out of the study because of the side effects. So there could be some, that is why the NFGARD study is coming. Next, third study is coming. And your question was budesonide?
Was it budesonide used alone or along
No,
with oral
not at all.
steroids?
Not at all. If at all, if you want to go, you should combine with the ACRBs. Optimized therapy. That's a usual thing happening in all these studies. Never with the other prednisolone, because this budesonide in the body is converted into 16 alpha hydroxyprednisolone and 6 beta hydroxy budesonide, which are all not at all having any steroid activity. That is theory, but practically it was observed there are some side effects.
If there are no more questions, I thank Dr. Jayakumar again for the excellent talk.
Thank you so much, chairs and speakers, for the wonderful session. I request Dr. Maman John and Dr. Suresh G to hand over the memento to Dr. KP Jayakumar. Thank you so much, doctors. So, ladies and gentlemen, we have two important announcements for you. Checkout time for delegates staying in Taj Green Cove is 11 a.m. tomorrow. So please make sure to check out after breakfast. Once more, checkout time for delegates staying in Taj Green Cove is 11 a.m. tomorrow. So please make sure to check out after breakfast. And the last session of today has been postponed to tomorrow morning at 9 a.m. as the first session. The last session of today has been postponed to tomorrow morning at 9 a.m. as the first session. So, ladies and gentlemen, we have come to the end of today's session. All the sessions were interesting and informative. See you all again tomorrow with more informative feast. Once again, thank you all. We shall begin tomorrow's session by sharp 9 a.m. We now disperse for cocktails and dinner. Good night.